is general practitioner from Victoria, Dr. Jackie Fankhauser. Dr. Fankhauser, thank you so much for joining us today.
Please call me Dr. Jackie, and it's my pleasure. I'm really excited all things lipedema.
Awesome. Thank you, Dr. Jackie. So let's get started. How did you first learn about lipedema, and what was that journey like for you?
So I was at home watching the project one night, and Dr. Rimin Shayan came on, and he started talking about lipedema, and I like what suddenly went off that I think this is a condition that I actually have. And I'd done postgraduate medicine, and I only graduated in 2013, and yet I hadn't been educated at all about lipedema in my 4 years at medical school. And I went to my own GP, said, I think I have this condition. I would like an appointment with Ramin. And it all went from there. It's just been a journey of discovery ever since, I suppose, because it's a condition that I also have. It makes me want to learn more and more to help my patients, to help develop awareness and understanding of the condition.
For sure.
And how did you feel like that you hadn't studied this, like that you didn't know about this medical condition?
It was frustrating. And the more, I attended the Lipoedema conference. Unfortunately, I couldn't go this year. I was at another conference, but I attended last year, and I was the only GP in the room. And I thought, how can we have a condition that, can affect 5 to 10% of the female population, and yet nobody knows about it? People can't diagnose it. And, we're not managing it effectively. So I think there's a degree of frustration, but I think, when you think about it, and it was only included in the International Classification of Diseases in 2019, it really, at the beginning of this huge journey to educate everybody, to research this condition, to provide effective treatment options.
Yeah, and we'll go through some of those effective treatment options a bit later on in the episode, which I'm excited about.
I think that is a really difficult thing because, we're in the advocacy space. We want to advocate. We want to educate the women living with lipedema, but we also need to educate our healthcare professionals at the same time, because if we have our community educated, but there's no one there to guide them and back them up. Like, we had a guest on last year, and she was diagnosed in 1998, but her doctor said, there's nothing you can do about it. So it's this really, horse before the cart or chicken before the egg, like what comes first? Yeah. And it's a really difficult space to be in.
Especially not being, in the medical space either. Shelley and I don't have any qualifications as a clinician in that sense. And so we don't really have access to that world to be able to provide that advocacy or knowledge.
Yeah. And I certainly know I'm a member of the RACGP, and at our annual conference that we had in Melbourne a couple of years ago, Ramin Shah did provide a session for the participants of that conference. The RACGP Victoria President, Dr. Rita Munoz, who I actually work at Healthcare on Collins, run online PD events as well. So, it's certainly an area that we need to do more work in. I would like to do more work in it as well. I've got a vested interest. But
yeah. Completely.
Yes. Yeah.
And speaking of your vested interest, if you don't mind, how does your lipedema present? Like, what were your symptoms, or are your symptoms?
I can look back to my kinder photos, and I always had, they used to call them in our family strainer post legs. Like, I always had chubby little legs. And then when I hit puberty, my legs just got bigger. I remember, there's a couple of times I remember being at primary school and a teacher saying to me, you can go to the notices from the office because you look like you need the exercise.
That's
You
funny.
yeah, and then, all through my teenage years, it's covering your legs. I love the water. I love swimming and not wanting to get into the bathing suit or, not wanting to expose my legs, always getting the longer skirts, the longer dresses, not having boots that could fit, having, boots actually hurt.
Oh,
Trying to go skiing and not being able to ski because of the pain in the lower legs and,
oh,
the yoga, the, being put on diets as a teenager, to lose weight. Miami Heart Foundation diet, Lordy. I mean, all of the diets that I've been on over the years. I think for myself, I realized that if I had those yo-yo dieting that I noticed real without even knowing what the condition was. I noticed it would worsen. So I, aimed for weight stability. So, that was something that I was always going, okay, whatever I eat or the exercise that I need to do, I need to really, this seems to be the weight that's okay for me. The point was my son's debutante ball and I got the photos back and I'd been on my feet all day and I was sitting down and all I could see was cellulite on my shins. And I cried and threw all the photos. And it was not long after you know, project. And this was me being in, within a healthy weight range for a BMI, had that degree of swelling. And at that stage, there was pain on palpation and always, easy bruising. Always, my whole life, it's easy bruising. But it was really, really a journey. For me, it was also to learn that I had bilateral lymphedema as well. I did not expect that. So, my surgical journey has been, you know, bilateral lymphovenous anastomosis to try to improve that lymphedema swelling before I could even look at the liposuction side of things. And once I started down that path, then I start research, compression, anti-inflammatory diet, um, compression pumps. I mean, Lucy Millican's my physiotherapist. Shout out to Lucy, she's incredible.
She's an
And,
amazing woman.
Sally Bay. Yeah, incredible. And, Sally Bay, Dr. Rimin's rooms as well is incredible. I mean, my sister's now been diagnosed, given the condition to my daughter. And I think that's something that we as mums, there's guilt associated with giving a chronic condition to your child, that you then see the struggles that
Absolutely.
they have with their body image and their identity. And that's not always an easy.
you're so right. Yep. So Shelley has 3 girls. I have 3 girls. And so Shelley's older than mine. Mine are still too little to work out what it might mean for them. But
Yeah.
yeah, it's always on my mind, actually, especially when they say, like kids have growing pains. I had growing pains. And when my kids talk about how they feel sore, I'm like, oh, no, it's all right. It's just growing pains. And I'm just like, oh, good. Please don't. Yeah.
Yeah. It is hard.
Yeah.
And was it, so you and your sister, so was there anybody else in your family?
My paternal grandmother. So she, and it's going back and looking at the photos. And I think that's a really important thing to do. And she was always a complainer. Like we thought she was just a hypochondriac, but she was always saying her legs hurt. Poor Nana Lynn. And then I now feel sympathy for Nana Lynn. Like it's like, wow, we just didn't know that that's what it was. And I was listening to Karen Herbst recently talking on a podcast about that we also need to go back and look in terms of obesity within our genetic history as well, both maternal and maternal, to see if there is that genetic component as well, which can overlay the life. Yeah.
Yeah.
Yeah, I'm hearing more and more about how lipedema gets worse if your lifestyle weight fat increases. And so, in a female body with all of our various hormonal cycles, not to mention pregnancy, where putting on weight is not the worst thing in the world as long as it's controlled. There's a limited amount of control that we have over weight fluctuations in our life. And so, what always comes to my mind is, at what cost do we try and maintain our weight? Like, do we need to be more sensitive to doing more things and using medications or other things to maintain our weight at any cost because of our lipedema? And it's that risk benefit way. And I don't think I have the answer, because we come from a place where we live in a larger body, we experience the world in a larger body. And so, is it that I just want to be smaller because I just want to be smaller? Or is now I want to be smaller because of my lipedema? And every time I get on the scales and I don't see the weight go down, I think, oh, I'm not doing something. But why does the weight always have to go down?
Yeah.
It doesn't always have to go down,
Yeah,
but it
that's right.
shouldn't go up.
Yeah, that's right.
And it's too bad.
And I mean, I do use the waist height rather than BMI and rather than the number on the scales. I know myself, if I would weigh myself in the morning and in the afternoon, I can have 1 to 2 kilos difference with the amount of
Absolutely,
fluid that I've
yeah.
accumulated over the day. And I'm really cognizant when I'm seeing my patients with lipedema of the battle of that scale. I think that, if we can try to keep that waist to height ratio, 0.5 or less, that to me is an indicator of health for lipedema women. And hormones are going to play such a huge role. Pregnancy, puberty, and, good old perimenopause. I mean, that's a whole nother journey. And I mean, I'm in that journey at the moment and regulating, trying to get control of the perimenopausal symptoms with menopause hormone therapy whilst not exacerbating the symptoms of the disease. And that's a balancing act. That's a real balancing act. And, I do, because a lot of my patients are coming to me at that perimenopausal time where they just go, this is just out of control for me. And it could be that they've been put on this menopause hormone therapy. That's the whole nother ball game.
Yeah, it seems too complex for my brain. I'm lucky that I'm a few years away from that. But, it could happen at any time, really. I mean, I'm 38. Is it postpartum? Is it perimenopause? Is it just normal, like, premenstrual stuff? I don't know. Like, pick one, anyone.
I think
Spin the wheel.
when you see hormone, it's hormonal fluctuation.
Yeah.
We need estrogen. Our body needs estrogen, but we also know of that complex interplay with estrogen and lipedema. And we don't understand all of it yet. But estrogen receptors throughout our body. We have them in our gut. We have them in our brain. We have them in our muscles. So our body does need estrogen, but, in our natural monthly menstrual cycle, we're going to get hormonal fluctuations. So, in that premenstrual period, when we get the fluid retention for a patient with lipedema, that can be significant fluid retention. If we're trying to, in the perimenopausal time, regulate somebody's and try to even out somebody's estrogen levels, that's where the challenge can be. It's an area that needs more research. And I mean, for me, my take home is that, women with lipedema can still have hormone therapy. They need the lowest possible dose for control of their menopausal symptoms. That topical is preferred over, a tablet form. But it's, where do we put it? A woman with lipedema can't put a patch on her butt or her legs or put the estrogel on her legs, her arms. The number of times, patients have said to me they, worsening of their lipedema in their arms. So when Karen Herbst was out for the conference last year, we had a discussion about this, and we were sort of talking about putting the patch or the gel on the sort of back area where there's less subcutaneous. Yeah. So, yeah, I would love more of us to know about that, so that we're
Yeah.
not, I mean, I put a patch on my butt and developed a lipoma underneath it. So,
Yeah.
yeah.
Okay. Yeah. Wow. It's
Wow.
so complicated. And if it's
We don't
complicated
know
for
enough.
medical professionals because there's not enough research, then it's complicated for everyone.
Yeah. Yeah, absolutely.
Yes.
So how has your personal experience with lipedema shaped how you approach it as a GP?
I think having lived experience always means that you're not just sympathizing with your patients, you're empathizing with your patients. And the journey of discovery that brings them to me, and it's often through social media or a family member having been diagnosed, and sense of when they're able to have somebody finally say to them, yes, this is the condition. When you talk about it being a chronic inflammatory loose connective tissue disorder, then that's overwhelming within itself, because as soon as you say something's chronic, and then it can be so overwhelming for some patients that they feel helpless, that they can't do anything about it, that they can't cure it, that they can't take a pill, that they can't use an injection that's just going to make it go away. But it's journey that I feel really privileged to take my patients on that journey as well, and help get plans for them and be alongside them. And I think also there's a real difference between being told, for instance, that you have to wear compression all of the time, 24 hours a day, or you have to follow a ketogenic diet. This is real life. What is it with life? It gets in the way of this. So, we know the high prevalence of eating disorders amongst our lipedema women, and sometimes being on a really restrictive diet isn't the best diet for them. So I think it's being able to be individualized with the approach, can't wear compression because of the work they do, talking about perhaps compression opaque tights that they can wear under skirts and dresses that are still giving some compression during the day. And then as soon as you get home, pop your compression on. So yeah, it's lived experience that I feel that I bring to the table.
And that would be just talking to you now with everything that you've said just feels so validating to talk to a medical professional who has that absolute empathy, and is going on this journey along with us. Like, I can't tell you how, like, my whole body relaxes into this because you're just saying everything that we experience. And so to be able to have someone like you to go to that's like, oh yeah, I know about this, and I know, oh gosh, we need you everywhere. We need to clone you. Yeah, I'm so curious to get into a topic about, especially when I said before, like, how sensitive do we need to be about maintaining or not putting on our weight, and at what cost, and what things should we use despite any I guess symptoms of it that would be beneficial for us. And something that comes into mind that's been talked about in the community a lot is the GLP-1 medications. And I'm on Wegovy at the moment. I've been on for a few months now. And the side effects aren't too bad, are very manageable for me. And my weight's going down, although I'm postpartum. So really, it's like, is it the medication or is it just time spent post giving birth? But I'd really like to tackle the topic of GLP-1s with you. Before we get into considering that for our lipedema patients, can you just explain what the GLP-1 medications are, and then what types there are? Because there are a few different ones, right?
Yeah. So there's the GLP-1s that have been around for well over a decade now. So, they were developed to treat primarily our diabetic population. GLP stands for glucagon-like peptides, and these medications work on that receptor, and they increase the amount of glucagon the body produces. And it's in the pancreas, but we know that has body-wide effects, and the most well-known effects are the effects that when you eat food, that you increase the amount of insulin that's produced. So insulin is that key in the door in all of the cells to unlock it and let the glucose go into the cell and do the job. But it's also got other important effects. You know, it decreases the release of glucagon from the liver. It decreases gastric emptying, is maintained for longer, and really importantly, it works within the brain on hunger hormones. So ghrelin is the main hunger hormone. So, you know, if it's working on that, you're not as hungry full for longer. And I mean, a lot of my patients really talk about food noise as being, you know, the real benefit from the medication. But it's not just that. We're actually seeing it's the type of foods that that we're craving, that it's not, you know, the carbohydrate is wanting. I mean, these medications we're starting to look at, can they be used for people with alcohol addiction? We're using them, you know, within the eating disorder population for things like binge eating disorder, and other effects on the body. We're starting, you know, the cardiologists and the kidney specialists going, well, they're good for the kidneys and they're good for the heart. And yes, they're an incredible class of medications. The other one, you know, the big one that everybody talks about now is Mounjaro or tirzepatide, and that's a G agonist, and that's a glucose-dependent insulinotropic polypeptide. So it works in a similar way to the GLP, but it's got a couple of extra effects we think could be particularly beneficial for patients with lipedema. And this is a medication that Dr. Thomas Wright, specialist in lipedema in the States, has been talking a lot about, and that we need to do more research. These medications have not been researched on patients with lipedema. I mean, at the moment, they're being researched on patients with obesity and with diabetes. So when we are using them for patients with lipedema, we're using them off-label.
Yeah, thank you for that. And look, in the community, there is a lot of discourse around people having great experiences with these medications in terms of their inflammation reducing, their weight going down, their food noise, as you said. But then there are conversely, there are people that have really bad side effects to it, not only physical side effects, but mental health side effects as well. So I wonder, when you're considering this class of medication for patients with lipedema, what guides that decision whether they should try it or not?
Yeah. I mean, some patients just come in and say, I want to try this medication. We go on
GP,
it.
I was like, just give me the script, please.
Yeah. I've done my research. And, you know, patients come in and they've done their research. They are aware of the risks and the benefits, and they're prepared to give them a go. For me, I often look at comorbidities. So I look at, is there comorbid obesity? Is there metabolic disorders? Are there insulin resistance, polycystic ovarian syndrome, you know, endometriosis, obstructive sleep apnea? You know, are there other conditions that I feel this medication could be helpful for? And that can guide. But for a lot of patients as well, these medications cost. And so I will discuss them and then talk about the cost and see whether or not, you know, that is something that is affordable for them. We know, so there's the two main ones. Semaglutide comes as the brand name Ozempic, and then the Wegovy. So we know that, Wegovy goes all the way up to, 2.4 milligrams, starts at, 0.25 milligrams, and you can Ozempic max it out as 1 milligram. It just for every, starts at 2.5 and goes all the way up to 15 milligrams. And every single time you do a dose increase, it's a considerable cost increase as well. So, I mean, you're looking at, what is it? You're looking at close to, I think it's $670 for the 15 milligrams per month. That's a lot of money.
Yeah.
Yeah.
The other thing that I really consider using these medications in are in patients in that operative period, already booked in for their surgery or they're keen to prepare surgery. I know that we want to get them, into the healthiest range that we can with their weight, to mean that surgery perhaps will be not as taxing on their body, because it is a very taxing surgery as well. So I consider that as, and yeah, and I do have patients who would be considered within the healthy weight range, for that waist to height ratio, who benefits of being anti-inflammatory, of being reduced swelling, reduced pain, and we're now seeing, particularly Mounjaro, reduce fibrosis. And if patients want to do that, then we're not looking at reducing their weight. We're looking at keeping them on a really low dose for those other benefits.
Yeah. And I suppose, when I'm looking online to like fitness professionals and stuff who are sort of demonizing the GLP-1 medications and saying people are using them and they're losing weight, which just proves that calories in, calories out is effective, because all it's doing is making them fuller for longer and getting rid of the food noise so they eat less. And I sort of feel like there's another piece of this puzzle. If we're seeing people with our condition saying that their pain is reduced and their inflammation is reduced, that's not just a mechanism of eating less food. It's not. So what is that? What's going on? And then you feel like a failure because you think, well, I could save $500 a month and just eat less, but it's
No.
not
It's
solving our problem.
It's more to it than that. It's a hormone. So it's doing so many other benefits than just making you eat less and weigh less.
And I think that's where the research is heading now. I mean, the Lipoedema World Alliance had there's a good podcast online where some of the world's leading experts on lipedema are talking about these medications, talking about the need for further research. Because when we look particularly at the GIP, so, the part of Mounjaro, then we are looking at that it's the decreased inflammation. And we're talking about body-wide inflammation. So affecting the heart, affecting the blood vessels. I mean, we know with lipedema, we get leak. If we're reducing the inflammation in those blood vessels, then hopefully we'd get decreased leakage of that fluid into, that interstitial space, where we're feeling it in particularly our legs and our arms. I mean, it's working on the inflammatory mediators. It's working on something called thermogenesis. So, the lipedema feels really cold. And that's because it's not very metabolic active. So if we can increase the activity within that little mitochondria, within that fat cell, that little energy, it's like a power station within that fat cell, then that's going to improve the health. Looking at the fibrotic tissue, if we can decrease fibrosis, we know these medications decrease fibrosis in the liver, fibrosis around the heart. They can hopefully work on fibrosis within our fatty tissue, within, that's holding extracellular matrix. So it is not just a case of calories in and calories out. And, if only you had more willpower, you would be able to restricting and lose and lose.
Yeah, look, I feel that in my bones, but then I see so much online about the fact that it's just like, well, it just proves that if you eat less, and it just makes me so frustrated. I'm like, what about the people with inflammatory conditions? What about the people with metabolic conditions? Anyway, I digress. Let's get back on track, Tiana. So I'm really interested to know, Dr. Jackie, if you've noticed any of how the different stages or types of lipedema, so people who are quite progressed in their lipedema or like the stage ones, or people with obesity as well, or people lipedema, people without obesity, how they respond to GLP-1 treatment. Are there any sort of like patterns that you've seen?
This is a really interesting area because these medications don't work for everybody. And I've had some patients that have had incredible responses for they're taking measurements of their legs, and they can see and feel that they're swollen, less inflamed, less painful. And that's not just the weight loss. They get weight loss associated with that. So it's very, very individualized. Side effects are also very, very individualized. I've got, some patients who have been unable to tolerate because of the side effects at the lowest dose of these medications. And I've got some patients who need to, they're getting no, but they're getting no response to the lower doses, and they need to, according to the monthly, go up to a far higher dose. So never ceases to surprise me. Every patient is completely different. In terms of the costs as well, I have to be very cognizant of that with my patients, that even though some of our early research is saying that perhaps Barrow could be disease changing for lipedema rather than just symptom improving, it is an expensive medication.
That's such a good point, Dr. Jackie, that there's such a variation in people's experience. And it just goes to show, like, I don't want this episode to be an advertisement for GLP-1 medications because, as you said, they don't work for everybody. And even if they do work, if you're having those side effects, it's not a good idea to keep going. If you're feeling terrible, like there's that risk and reward sort of thing that you need to weigh up. So I'm glad that you mentioned that it doesn't work for everybody because you're absolutely right. And we need people like you to guide us through those things, to really talk through, well, are these benefits outweighing the risks, or do you probably need to stop or titrate down, or
Yeah.
Because
Yeah.
not every tool is for everybody.
yeah.
And so if a patient expresses the desire to start these medications and we talk about, well, which one financial can you afford? And there's a lot of education regarding associated with the medications, and also the need for this to be there has to be the associated lifestyle modifications that go along with it as well. I encourage all of my patients to see a dietitian, be under the care of a dietitian, to ensure that not only are we getting adequate protein intake, but that we're actually getting adequate food intake, because a lot of patients have no appetite on these medications and eating, they're skipping 2 meals a day and eating once a day, which is not good for health.
Absolutely.
So, just making sure that we've got the right amount of calories, the right type of calories going in as well. And alongside that, you know, if we're looking at it for the weight loss side of things, you know, the body has a choice. Is it going to lose, you know, or shrink the fat cells, or is it going to take fat from elsewhere? For instance, is it going to use the muscles? And so, you know, there's a lot online about, you know, reduction in lean muscle mass on these medications. And so all of my patients get counseled that it's potentially going to be a 50-50 ratio unless they look at doing something which is not just exercise. It has to be something to stimulate the muscles. And so that there is resistance training or something like a clinical Pilates where you're actually stimulating some muscle growth as well. So, you know, and then I monitor, I follow my patients really carefully. You know, initially it may be every month, and we decide we need to go up a dose. I have a kind of rule of thumb. If somebody's using it for the weight loss side of things, I want, you know, realistically around 500 grams a week. And then, you know, I don't go to the next dose unless they're getting plateaued. And in my experience, there's not a lot in the literature to say that you build tolerance to these medications, but in my experience, they do seem to be, for the majority of my patients, they will get to a stage that they go, that's at the stage that I go, okay, you're paying big bickies. We want bang for your buck. Let's take you up. Let's take you.
Yeah, that's the other thing that I grapple with as well, because we know without the use of medications, when you're on a weight loss journey, there is a plateau. And it's either then try and maintain and increase your calories so your calorie deficit is like supported, I suppose, because you can't just keep going down, 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 down in calories because you'll end up eating like a bird and then putting on
No.
weight. And so it's like, how do we work out whether a plateau is beneficial for a time, or whether you just push again and increase the dose and just keep seeing that progression going down? It's really confusing when you get to that plateau stage about what to do next.
Yeah.
And I mean, I counsel my patients that if you're, like I said, eating the same, exercising the same, there hasn't been birthday parties, it hasn't been Christmas, you know, I think we have to be a little bit forgiving. And also those hormone fluctuations that we talked about earlier, they can be a huge impact. You know, I really don't like my patients to weigh themselves too often. You know, if they want to, I really don't want them doing it more than once a week. And because I think that can be very frustrating for them to not see the movement. So, you know, I've got some patients, particularly if they've got a history of eating disorder, that I'm the only one that weighs them.
Yeah, okay.
And again, each time I review them, I check their waist circumference because, again, as we said, I'm all about waist to height ratio. That and that's a decision that sometimes they'll say, "Oh no, I've just, you know, X, Y, or Z's happened. Let's just stay on this dose a little bit longer." But then we have to go, well, there's at a point we know, you know, that we can, if we're looking just at, you know, weight, that these medications tend to have their limit at around 20%
Yeah.
loss of body mass. And then, you know, some people do reach that. If I'm using it for the anti-inflammatory benefits, the actual in pain and swelling, whole different scenario because, you know, and then you might have heard online the people talking about microdosing
Yeah.
with these medications and having really, really small doses. And, you know, I've heard podcasts, they talk about, you know, a tenth of the usual. The difficulty with this is that these medications were not designed to be microdosed.
Sure.
That so we don't know the effect on the body because, you know, we're buying a product. There's a lifespan that has been given to the medications. So, they say after 8 weeks that the Ozempic can, or the Wegovy would max out after 8 weeks. Mounjaro, they're saying 4 weeks. Now, whether that really is 4 weeks or not, I've certainly got patients who are choosing to extend it and, do half that dose. And as a GP, they're entitled to their autonomy, but that's outside of what currently the medical profession is recommending at the moment. But, I do have some patients who don't want it for the weight loss. They just want it for the benefits that it gives them for their lipedema. So again, I would like to see that this is an area that we can research in the future to make these medications specific for our population.
Yeah, absolutely. I would like that too. I'm so curious about everybody's experience. Because I'm not a researcher, I look at anecdotal evidence, and of course I'm looking online because you're flooded with it.
Yeah.
And a lot of people in the lipedema community are really benefiting from it for various reasons. As you said, either the weight loss or the inflammation or the pain, or the pain and the inflammation, works together. But I'm just fascinated by it all. And I must admit, in my experience, the weight is going down incredibly slowly, and I'm at a plateau at the moment, but I still experience pain. So the inflammation part of it and the pain part of it, the Wegovy is not hitting it for me. And so, to be fully transparent, I'm thinking about switching to the Mounjaro, but the cost associated with it is really just a big barrier for me at the moment. And do I switch to Mounjaro, experience great benefits in my pain and inflammation, but can't sustain it financially?
Yeah. And when you are switching, I've got a lot of patients who haven't responded to Mounjaro and thus to Wegovy and vice versa. And you do have to, they are different medications, because the Mounjaro has got the GIP as well as the GLP receptor. You do have to go back to the start again and go down. If you were wanting to switch across, then you'd have to go back. So that would be cheaper for you to do that. But you may find that the 2.5 milligram lower dose of the Mounjaro is working incredibly for you. We need for these amazing individuals worldwide to do the studies on our population to see which one really is going to be the best for us longer term.
Yeah, here, Dr. Jackie. I feel like we could talk about this for a little bit longer, but I'm just cognizant that we usually stick to half-hour episodes and we've gone over time. But thank you so much for putting your own personal experience and then the experience that you see in your GP clinic. I think the most important question, especially for those people, our listeners who live in Victoria, is where can the lipedema community find you?
Yes. So I consult out of Healthcare and Collins, right in the Melbourne CBD, nice and close for people to come and shop. I've been privileged enough to look after patients who've come from interstate, so from Tasmania or Queensland, and they have face-to-face. Medicare allows it if they have face-to-face consult with me, that they're eligible for the next 1 year to actually telehealth with me, so we can do video.
When's that reach then?
Wow, we might need to go down to Melbourne for a week.
Come down and visit. So yeah, I love our lipedema patients. They're always the highlight of my day. And 4 days a week there at the moment.
Wonderful. Dr. Jackie, thank you so much for your time today. We've really appreciated it. And hopefully we can get you back on another time.
Yes, thank you so much for
Love
joining
to
us
come
today.
back, to come back. It's been fabulous listening to your podcast, and just thank you for doing the work that you're doing. We need to get this out there. We need to educate and advocate our population, our doctors. I'll do what I can on my end.
Yes, and
Thank
thank
you.
you for that. Yeah.
Bye.
Bye.
The Lipedema Podcast 2025 is powered by Elegance Lymphatic Care. Lipedema and its symptoms vary from individual to individual. The opinions and advice voiced in this podcast are of a personal nature and used for educational purposes.
Please take away from this podcast what resonates with you And please see your GP or preferred specialist for diagnosis and healthcare. We are Shelley and Tiana from the Lipoedema podcast. Until our next episode, bye for now.